Thank you, Mr. Chairman and members. Again, my name is John Hawkins, and I'm here representing the Texas Hospital Association, and we are testifying in support of Chair Coleman's bill. I want to echo the praise for Chair Coleman for taking the lead on this issue and really looking for innovative ways to deal with the uninsured in the state. You've heard a lot of good testimony already. I think Ann gave my presentation, so I might just sit down. But that's not unique. I do want to talk a little bit about the impact of the uninsured on hospitals in the state and give you a little bit more color around that. And I've got a handout here that talks about hospital financing in the state and how much we do rely on those supplemental payments. But the reality is we've got, as was noted, more than 4 million uninsured Texans, almost 5 million. I will remind you that under federal law, those folks have to be treated at a hospital regardless of ability to pay or their insurance status. And just consequently, that also has an impact of about $4.5 billion of cost to Texas hospitals, and that is a number that we report to the state at cost. That is not a charges number, which I know sometimes can be confusing. So the reality is that cost, Chair Turner, does get not only passed on to local hospital districts if you're in an area that has a taxing jurisdiction, but also the private market at some level, because that is a cost that's borne based on federal law. And so that cost has to get shifted elsewhere. So the reality is we do rely on these supplemental payments to make up the difference. And really the state has kind of cobbled together the safety net over the last 7 years because of the 1115 waiver. And I think, Ann pointed out that situation is changing markedly. So we've got the waiver, which is about $6 billion. DSRIP is phasing out. We are hopefully going to be able to run some of that through the Medicaid program. But again, if we don't do something about the working poor, that could only benefit kids in most cases. We're also working on a continuation or a proper sizing of our uncompensated care pool, but I can tell you CMS is really ratcheting down on the way they're looking at those pools. Office of Management and Budget has a role in that as well, because they're looking at the federal expenditures on supplemental payments, especially when they know there are other funds that are set aside that could ostensibly deal with part of this population at a 90-10 match. So that game is going to change very much going forward. It's also not likely that we're going to get the same budget neutrality calculation. So really our waiver is we're reinvesting the savings in our managed care program and allowing it to go into these supplemental payment programs. We got a favorable budget neutrality calculation in this new waiver. But again, CMS, OMB, at some point the pressure is going to be on to rebase that budget neutrality calculation. So that will be very challenging going forward. The other source that we haven't talked about is the disproportionate share hospital payment program. And I should go ahead and pass that out. But remember, too, under the ACA, and when we talk about these federal funds, it's not a situation, I would argue, where we're adding to the federal deficit. Remember that the ACA was funded at least half by provider cuts, which actually began to go into effect in 2011 and actually increase over time, as the expectation was providers could offset that with coverage expansion. Obviously, that's been a challenge, as Stacy pointed out, given what's going on in the marketplace, and it's really a challenge in a state that didn't address coverage expansion under those Medicaid funds. So really, that graph there shows how those cuts increase. Those have primarily been Medicare cuts. There are Medicaid DSH cuts that were supposed to go into effect. We've been able to delay those because of these challenges with the ACA, but those actually go into effect in October of this year if Congress doesn't act to intervene. And so that's a $4 billion cut. Texas is one of the top 5 states in the DSH program, so that's probably a $300 or $400 million cut to Texas in the DSH program. So we're not able to address this expansion population. Uncompensated care keeps going up. The Medicaid DSH program is about to be cut, and we're not likely to get a favorable waiver going forward. So we really do need to figure out an innovative way to access these 90-10 federal funds. Chair Turner, I should point out too, when you look at other states and recognizing that, even 10%, the state share can be a challenge in the state budget, particularly given the size of Texas. The reality is most other states, conservative states, have done that in a way that doesn't actually use general revenue. They have used savings from other general revenue programs, and as Ann pointed out, we're already putting up local funds to draw down state share both in the DISH program and under the waiver, and so it's likely we would just be able to redirect some of those to cover the state share if the benefit package was generous enough to offset that cost. So we argue, looking at other states, we could do that in a way that would not be additional general revenue. And that, again, as you pointed out, that doesn't even impact or take into account the stabilization or even potential reduction to local property taxes. So I'll stop there and answer questions.
Dr. Oliverson?
John, I appreciate your testimony. So is it your thought then that this bill, if it passes, sort of takes the place of the waiver and we don't have to apply for that anymore?
Yeah, I think very likely we wouldn't. I mean, obviously there are still some savings, we think, in our managed care program that we might want to argue for additional add-on payments, particularly for behavioral health and some of the other things that have had good outcomes. So we could potentially still have a more limited waiver, but and remember, the old waiver was actually it was called a transition to coverage because it was negotiated before the Supreme Court ruling. So it was really built to help create some innovation, some community infrastructure to build that expansion into. So
I just want to understand. So if this is primarily sort of a coverage expansion bill, are your members benefiting from this just because essentially they don't need all these extra sources of income from the feds because now there's less uncompensated care? Is that's the assumption?
Correct. You would have less of a need for that uncompensated care pool.
Okay, so then the DISH actually ends up being not as relevant either, even if it gets cut, right? Because your uncompensated care goes down dramatically.
Correct. And if we could use, we're doing some things on rates. The Uniform Hospital Rate Increase Program that I point out here, we're actually able to build up the rates, and so that's helpful because it reduces the Medicaid shortfall, which both DISH and the waiver are covering as well. Okay.
And then, I should have asked this earlier, but maybe you can answer it. As you read the bill, your understanding, or maybe Chair Turner, are we anticipating a Medicaid managed care type expansion here where we're actually going to have our managed care companies actually managing these patients and making sure, establishing networks and making sure that, it talks about quality metrics and various things that are being contemplated. I mean, who's going to implement all of that?
Correct.
Or is this just sort of fee for service?
No, we fully anticipate. In fact, we as THA would support actually, putting these folks into the commercial market using the networks that we've already created under our Medicaid managed care. So no, it makes no sense, and I don't think CMS would ever sign off on something. They're trying to move Medicaid to more of a value-based payment. So we fully expect that you would build it into that system, obviously with just much deeper subsidy because of the population that you're covering.
And then last question, your thoughts as affiliated with THA is sort of on, I know you primarily represent some of the larger hospitals, but with respect to, we keep hearing about rural hospitals and some of the financial difficulties they find themselves in. Does this improve their lot as well?
Absolutely. I think when you look at the states who haven't had rural hospital closures, it's been the states that have figured out a way to do the coverage expansion piece.
And again, that gets back to the fact that they have a higher disproportionate share of uninsured patients in rural communities, and so the snowball just gets bigger and bigger.
Correct. And it's harder to build these supplemental payment programs that work well for them as well. Those are usually multi-hospital systems that are able to make those work.
Okay. Thank you.
Thanks.
Representative Turner.
Thank you, Mr. Chairman.
Chairman Turner.
Thank you, Mr. Chairman. Thank you for your testimony, Mr. Hawkins. A couple of questions. I wanted to go back on the history of all this. When the ACA was passed, and you alluded to this in your testimony, so that there wouldn't be. Okay, my phone thinks I'm talking to it. I apologize. When the ACA was passed, in order to not add to the federal deficit, the Congress had instituted a variety of cost-saving measures, and a lot of those impacted hospitals. Is that
Correct.
right? In terms of, you frankly weren't going to get the same streams of funding that y'all have been getting historically.
Correct.
And
Correct.
so that they achieved that. I think they were going for deficit neutral. It was actually a deficit positive impact, according to the CBO at the time. But that was predicated on the hospitals would make it up, because now you would have expanded coverage both through the marketplace and through Medicaid expansion, right?
Correct.
So you would have much less uncompensated care than historically.
Right.
Okay. But then the Supreme Court in 2012 ruled that while the ACA was constitutional, the Medicaid expansion, that was a decision to be left to the states, not mandated by the Congress. That's essentially what the decision.
Correct. In
Yeah.
fact, made it optional for
Yeah.
states.
And so in a state like Texas that has not expanded Medicaid, I mean, in reality, the hospitals are getting the worst of both worlds, because the cuts in the bill take effect no matter what, whether a state expands Medicaid or not, right?
Correct.
So just because the state doesn't expand Medicaid doesn't mean the cuts are magically restored.
Right.
You still have to live with those, but then you don't realize the benefit of reduced uncompensated care through Medicaid expansion in states that have opted not to do that.
Correct.
Okay. So, and I think you just said it, in states that have now expanded Medicaid, you're seeing less of a closure of smaller rural hospitals in those states?
Yes, I think actually Kaiser's done some good work, and it's on their website, where they looked at the financial challenges for rural hospitals, and just when you look at the map, the preponderance of those are in the non-expansion states, the rural hospital closures.
Okay. And then finally, you alluded to this at the beginning of your testimony about, and I'm glad you did it, obviously there's a positive financial impact on public hospitals, like I mentioned a minute ago. But for all hospitals, there's would be a positive impact, because right now the brunt of the uncompensated care load is borne by everybody.
Correct.
Right.
Correct.
And I think y'all, maybe I'm wrong on this, I think your association put out data before that shows sort of the impact of the uncompensated care or uninsured rate in Texas on the overall cost in the system, as well as the cost of health insurance premiums for those of us in the private
Yes.
marketplace plan. And it's I forget the numbers, but it's considerable, is it not?
Yeah, and I don't have those right on hand other than just these base numbers. But yes, it is significant. And again, none of that even accounts for, you assume there would be better outcomes just from moving that to more preventive care as opposed to just episodic care.
Which also reduces the overall cost, and then should reduce.
Correct. And again, remember, that was a whole other component of the ACA, was the move to more of a value-based payment for both Medicaid and Medicare.
Yeah. So essentially, we right now subsidize our huge uninsured rate through state budget, through property taxes, and through our private health insurance premiums.
And the federal supplemental payments, which again, that's where I think the OMB has come in, and in a state like Texas, that trend line is unmanageable from their standpoint as well.
It's not sustainable.
Right.
Yeah. Okay. Thank you.
Thank you. Members, are there any questions? Thank you so much, Mr. Hawkins.